Everyone, my name's Kush and I'm a 5th year UCL medical student. In this talk I'll be going over steatorrhea and cystic fibrosis. We'll go through a short case, talk about cystic fibrosis and the management, and then go through an SBA. Don't worry too much about the details, but we'll go through the main points that you need to take home at the end of the summary. Right, so on with the case. You're in GP and a 5-year-old female presents with her mother with a 6-week history of diarrhea and growth problems. The mother describes foul smelling, difficult to flush stools, which is steatorrhea, fatty diarrhea, and there are no diet changes, no abdominal pain or vomiting, and also the child is not growing as expected, which is failure to thrive. An examination, the patient is malnourished with finger clubbing, as you can see in the picture. The abdomen is soft and non-tender, there's no distension, ulcers or rashes, and the height and weight is below the 5th centile, which confirms failure to thrive. Differentials for malabsorption in children: inflammatory bowel disease, celiac disease, cystic fibrosis, pancreatic problems, GI infections or intolerance, and thyroid problems. With clubbing and failure to thrive, you'd think highly of inflammatory bowel disease, celiac and cystic fibrosis. And the investigations, you'd request stool culture with ova and cysts to look for infection, a celiac screen, thyroid function tests, calprotectin to look for inflammation, elastase in the stool to assess for pancreatic function, and an additional assessment to look for deficiencies. The results come back and there's a low fecal elastase, which indicates pancreatic insufficiency, and the other tests are all negative. At the next appointment, the mother mentions polydipsia and polyuria in her daughter, which means she's drinking a lot and passing a lot of urine. So which complication does that describe, and what's the most likely diagnosis now? Have a think. So the answer is diabetes mellitus and cystic fibrosis. And so you do a sweat test that comes back with a raised chloride confirming cystic fibrosis. And the complication that's developed is cystic fibrosis related diabetes mellitus, and that's confirmed on glucose testing. And we'll explain why those two diseases are related in just a moment. Just a bit of background about cystic fibrosis. It's an autosomal recessive condition, common especially in Caucasians, and 1 in 25 of us are carriers, so it's quite common. Mutation occurs on chromosome 7 in the cystic fibrosis transmembrane regulator gene, which is essentially a chloride channel. And all the mutations have the effect of causing a defective chloride transport across the cell membrane. So if there's less chloride being secreted by the cells, that means there's less water in the secretions via osmosis, and then you get thick, viscous, dry secretions. In the pancreas, what that means is that the enzymes get stuck in this thick, clogged up mucus in those pancreatic ducts, and they start to self-digest the pancreas, causing inflammation and fibrosis and damage. That means the enzymes don't get to the bowel, so there's malabsorption and steatorrhea or fatty diarrhea, and there's also failure to thrive from the malabsorption. It's a multi-system disease, cystic fibrosis, and the chloride transport issues underpin the diagnostic sweat test, which looks for an excess chloride in the sweat, as the chloride can't cross back into the cells, so it remains in the sweat. And also, obviously, if you get pancreatic damage, you can damage insulin production, causing diabetes mellitus, as in the case. And there's an increased risk of rectal prolapse and gastroesophageal reflux in cystic fibrosis patients. And also liver damage, because the same effect of thick, dried up secretions in the bile ducts can cause cholestatic liver damage and even portal hypertension in some patients. Back to the case. So in terms of management, managing the malabsorption, you'd manage that with a high calorie intake to counteract loss, vitamin supplements, especially the fat-soluble ones, as fat absorption is affected, enzyme replacements taken with meals, and proton pump inhibitors have been shown to optimize the pH in the duodenum for better absorption. In terms of diabetes, you need to give insulin if that complication develops, and monitor the height and weight and BMI, as these are important prognostic indicators, and it's a good monitoring of how treatment is working. And you can also monitor for varices if liver disease is present, and liver transplant may be required in some patients where there's extensive liver disease. Cystic fibrosis, in terms of the outlook, there's many new treatments being developed, such as CFTR modulating treatments, which can help expression of a functioning chloride channel. These have been shown to improve prognosis. There's also gene therapy and stem cell treatment, which are in trials. And cystic fibrosis affects many organ systems, has an increased mortality, associated psychiatric burden of chronic disease, and carries a reduced life expectancy. And so it requires multidisciplinary lifelong management. and it's very important to pick it up. Always think of it if you see a child with failure to thrive and chronic steatorrhea or diarrhea. On to the single best answer question. So a 10-year-old has recently been diagnosed with pancreatic insufficiency secondary to cystic fibrosis and haven't started treatment yet. Due to this pancreatic insufficiency, which of the following are most likely to be seen? So number 1, weak bones, night blindness and hemorrhagic disease. Bleeding gums, easy bruising, myalgia and hair loss. Number 3, dementia, diarrhea and depression. Number 4, confusion, ataxia and ophthalmoplegia. Number 5, neuropathy with loss of vibration sense and upgoing counters. Okay. So have a moment to think about that. You can pause the video if you want some more time. It's a tricky one, so don't worry. The answer is number 1, weak bones, night blindness and hemorrhagic disease. These are all the signs and symptoms of deficiencies of vitamins A, D, E and K, which are the fat-soluble vitamins. And because of the lack of lipase in cystic fibrosis patients, you get fat malabsorption, and that means the fat-soluble vitamins are worst affected. And so patients have to take these ones, A, D, E and K, as supplements. And the water-soluble vitamins and the other options aren't as badly affected. So that's all. So here's a summary of the key points. Steatorrhea is greasy, fatty, difficult to flush stools caused by fat malabsorption. Failure to thrive is when the child doesn't meet their growth milestones. And if you see both steatorrhea and failure to thrive in a child, you should always think of cystic fibrosis in your differentials. You can do a fecal elastase test to test pancreatic function and a sweat test to confirm the diagnosis. And the mainstay of management of pancreatic insufficiency is a high calorie intake, vitamin supplements, and enzyme replacements, and of course long-term support for the patient and a multidisciplinary approach. That's all from me. I hope that was useful for you. Here's some resources that might help you with your revision. If you've got any questions, feel free to email me. Thanks very much for your time and take care. Bye.